The three bones of the shoulder include the clavicle, the humerus, and the scapula. The muscles include the deltoid, the anterior, middle, and posterior, and this is the prime mover for shoulder flexion. The pectoralis major and minor assist in shoulder flexion and adduction. The trapezius and rhomboids support scapular positioning. And the supraspinatus muscle assists in abduction, and it is the most common to get injured. The infraspinatus controls external rotation, and the teres minor assists with external rotation as well, but it also provides stability. The sternoclavicular joint links the clavicle to the sternum, providing stability. Then the acromioclavicular joint connects the clavicle to the acromion process of the scapula, and the glenohumeral joint is the ball and socket joint that is mostly responsible for most of the movement, and it is also typically the most common to get injured because it provides so much movement and rotation. Then we have the scapular-thoracic joint. It is not a true joint, but it allows scapular movement on the rib cage. Then we have the glenohumeral ligament that provides anterior stability to the glenohumeral joint. Like I said, it is the one that allows most movement, so it is very easy to get it injured, so the ligament provides lots of stability. Then we have the coroclavicular ligament that stabilizes the AC joint, and the transverse humeral ligament, which secures the biceps tendon. And right here we have a flexion. An anterior dislocated shoulder occurs when the humeral head, the ball, is forced out of the glenoid cavity, the socket of the shoulder joint. And this usually happens because there is less muscles and tendons and joints in the anterior side than the posterior side, so it makes it easier for the humerus to pop out of the socket. Signs and symptoms can be intense sudden pain, visible deformity, the inability to move the arms, swelling and bruising, numbness or tingling, and muscle spasms. After a dislocation, you should seek medical attention right away. Don't do anything yourself. It has to be popped back in place by a professional. There are recovery warm-ups and stretches and exercises you can do. These wall walks help flexion and abduction. You face a wall and use your fingers to walk your injured arm up slowly, and you hold for 5 seconds, then walk back down, and repeat this 5 to 10 times. This improves shoulder elevation without strain. You can also do pendulum swings by bending slightly forward, allowing your injured arm to hang down, gently swinging your arms forward, backward, side to side, and in small circles. This loosens the shoulder without active muscle use and promotes joint lubrication and reduces stiffness. After the warm-ups, we can do some strengthening isometric shoulder exercises. This improves external rotation, and you stand with your injured arm against the wall at a 90-degree angle, and you push outward. You can also do internal rotations by placing your hands against your stomach and pushing gently inward. You can also do a scapular squeeze. This improves posture and stability. You sit or stand tall and squeeze your shoulder blades together. This helps restore scapular control. Once your strength improves over time, you can progress to a more functional movement like wall push-ups. You can start with your hands on a wall and perform gentle push-ups. As you progress, you can even let go of the wall and then incorporate maybe some push-ups or even a bench and added weight as you get stronger.